The one I'm about to do could be either, because it's about stroke, and it's really about TPA for stroke. How many have heard me talk about this before? It's one of the things I feel pretty strongly about, not so much because of the medicine about it, but because of the politics and money that I think are stoking this whole discussion. And to me, that's very troubling, the way in which money and politics interfere with us trying to do what's best for our patients. So if we were really to talk about stroke from the standpoint of what do we really know and should we be using these drugs, we could spend a lot of time. We have, in this course, we have had a lecture on stroke, and particularly TPA for stroke, almost every year for the last few years. And nothing new is there. So in that sense, if we wanted to just sort of say what's new in the last year, there's almost nothing that's new. But I suspect that some of you will want to sort of go back over the big picture. So we'll try to find our way in the next 20 minutes and figure out, or half hour, figure out what we want to talk about. This chapter was written originally from the standpoint of what's all this stuff about regionalization? Now, I'm going to just guess, how many of you are in a community where they're talking about regionalizing stroke care? And what's the impetus for that? Why? Okay, so the truth is, of course, the answer is always, of course, TPA, but what do they say the reason is? Better outcome. So what makes a better outcome? Better rehab. So the first thing, great. So the first thing to say is there is some evidence, there's no randomized controlled trials, but there is some evidence that seems to be pretty consistent that when you treat people in a stroke unit, they do better. And the first article mentions that. It's from the American Stroke Association and the American Heart Association. What's the difference between the two, by the way? The Stroke Association is part of the Heart Association. It's sort of fascinating. I don't know how the heart got up into the brain, but the Stroke Association is a subset of the Heart Association, and it's all driven by TPA. I mean, it really is. In fact, as some of you know, the Heart Association has received millions of dollars from the makers of TPA. They built them their new building in Dallas, many millions of dollars. And that was a secret until a reporter named Jeannie Lenzer found it out when she was exploring the Heart Association's recommendations about TPA and how this all happened. And so she found this out. But in any case, the Stroke Association and Heart Association published this article. It's the first one, number one in your manual a couple of years ago, which said we really need to regionalize. And they cited during that, the bulk of the article cites the fact that if you get care in a stroke unit, you do better. Now, I think I included in here a couple of articles about stroke units. Last year, we included a whole bunch of articles about stroke units, and they basically showed that if you're treated in a stroke unit, you do better. Number two here, I think, actually asks the question that's really important: why do you do better? Why do you do better in a stroke unit? We'll get back to number one in a second, but they're saying you do better in a stroke unit, better outcomes, so let's do it. Let's bypass the local hospital, take you straight to a stroke unit. Oh, by the way, you don't have to bypass the local hospital if the local hospital has a stroke unit. So, and for the most part, to be a stroke center, you don't have to do a lot. You just have to say, I'm willing to do it. Well, that's not exactly all you have to do. We'll get back to that in a minute. But so if you get treated at a stroke unit, and the local hospital could be a stroke unit if they choose, but if they're not, you should bypass them, according to the Heart Association. You have better outcomes. So number two asks, what is it about stroke units that provides good outcomes? They don't really see, the authors didn't ask that, but you can read that from the paper. I'll tell you how in a second. So what is it that what is it about a stroke unit associated with good outcomes? Well, let me tell you this. They looked at, here's what they did in article number 2. They looked at who does better. So they looked at, what if you have a stroke ward? And that does really, really well. If you get admitted to a stroke ward, you do really, really well. They looked at, what if there's a stroke neurologist who takes care of you? And how'd that do? No difference. Didn't matter if you had a stroke neurologist. How about a stroke team? No difference. Well, actually, there was a difference. It was just, if you separated it out from a stroke ward, there was no difference. So when there was a neurologist but no stroke ward, it didn't help. When there was a neurologist and a stroke ward, it helped. When there was a stroke ward and no neurologist, it helped equally much. Same with the stroke team. The stroke team was really good if it was tied to a stroke ward. It was no good if it wasn't. So that actually, it seems to be the important stuff was you were treated on a stroke ward. Now, what do they do on a stroke ward? The first thing to know is it didn't matter if they had a specialist. So what they were doing doesn't seem to have anything to do with special neurologic care. What was it that they did on a stroke ward that was good? What do you think? They paid more attention. And they paid more attention to a couple of important things. What? What? Swallowing. They made sure they didn't aspirate. That's really complicated stuff. What else? If you had a fever, that's bad for the brain because you're metabolizing fast. So they treated fever early. And they turned to people more. And they started rehab earlier. That was it. Those are the things that are associated with good outcome. They're really important. They're really associated with good outcome. Which of those do you have to bypass the local hospital for? You know, it's sort of funny, but there are two reasons why you don't have to bypass the local hospital. One is the local hospital could do that if they wanted. Maybe a better solution would be to have the local hospital pay attention. And two, not just the local hospital, the local ward. If you're treated in a stroke ward and the very next ward over, which is not called a stroke ward, in the same hospital, you do much better on the stroke ward with the same specialist and the same admitting doctor. It's because they pay more attention. By the way, where else does that occur? Well, it occurs in COPD wards. It occurs in diabetes wards. It occurs in CHF wards. That is to say, when there is a group of healthcare providers who know that we're supposed to pay attention to this disease, patients do better. It has all to do with nursing care. It has nothing to do with medical care. It has to do with doing what we all know how to do. There's no special expertise. It's just paying attention. I don't have to remind most of you the dirty secret that people don't know, but we all know that in a hospital ward, there's a lot of inattention, right? The patient goes there, and the most important thing is the buzzer doesn't get answered. You talk to any patient, right? They press the buzzer 95 times and nobody answered. Well, if you answer the buzzer, simple things like that, if you turn the patient, do those things, outcomes are better. What if that is emergent? Well, of course, nothing. A, your hospital can do it, and B, even if your hospital doesn't do it, there's no emergency need to have EMS bypass. You could certainly say, let's take them to the hospital, do whatever you have to do, and then on day 2 or 3 or whatever it is a stroke, they need to get all that attention, let's send them over there. So there's nothing about this that's emergent. So what is the impetus for emergency regionalization? Well, there it's pretty straightforward, right? The only thing you do in stroke that's emergent is TPA. So in order to become a stroke unit and get certified by the Heart Association, you basically have to say, oh, we're going to be a stroke ward and we're going to be really good. And we promise on our, Scouts honor, we're going to do all the right thing. And we will give TPA. Because there are a lot of hospitals that don't give TPA. Nowadays, there are fewer. Why is that? You don't give TPA, you get sued. So everybody's scurrying to get do PPA. Because I'm pretty outspoken on this, I get called a lot of times to defend doctors who are being sued. There's an avalanche of suits out there. And most of them, in our legal system, it takes, it's done in glacial time. So I'm still seeing suits from 2000 and 1998. And in 2000, 1998, and 2002, most community hospitals weren't offering TPA. Or even if they had a protocol, they never gave it, because almost nobody qualifies. But every single one of the suits that I've seen, they now have a protocol. Once the suit occurred, they decided this was really, really important, and they made a protocol. So I think the real push for all of this has to do with TPA. Now, I could ask you, what's happening at your hospital? Anybody here where the hospital is not offering TPA? There's a few, okay? Good. We'll see what happens in the next couple of years. Well, there may be some exciting developments I'll tell you about in a minute. But anyway, so I think that's what this is really about. And that sort of takes us to, and they mention that in abstract number 1, where they talk about the importance of bypassing and regionalizing and all that stuff. And the comparison that they make, by the way, in abstract number 1, is it's just like trauma. We have trauma centers. Why don't we have stroke centers? But I think it's the absolutely most ludicrous comparison. Because trauma, it does matter whether you get treated now. It doesn't matter what happens 3 days from now. It matters right now. This is the exact opposite. It's the comparisons are diabetes units. There's nothing emergent about that. So anyway, that's where this all starts. Now the rest of the chapter says, what do we know that's different in the last year or two? And the answer is nothing. There's nothing new. There's almost nothing new. But there's a few things that are worth talking about that I'm just going to run through. I apologize because if we had a lot of time, I would talk about what's the totality of the evidence. And I think the totality of the evidence is pretty compelling about TPA. I personally believe the evidence is really clear-cut that, that this stuff doesn't work. Or at the most, it works a little teeny bit and likely causes a little bit of harm. But that in the big picture, it's very unlikely to be important either way. And so for me, the real important part of this has nothing to do with we're killing people with this terrible drug TPA or we're making miracles. It's why have we allowed politics to run medicine and to answer controversy? That to me is the real important question. We'll get back to that in a second, but not just politics, but also money in its most basic sense. So why is there this avalanche of lawsuits? You know, where'd that come from? Anyway, let me just run through some of the other things that are in here. The first, article number 3, is, I think, an important article. It's from some prominent neurologists in Scotland, and they're sort of TPA advocates. And they're not the zealots like some people are, but they're certainly advocates. And they talked about, you know, when our stroke team got called because somebody thought it was a stroke, how often did it turn out to be something else? That's called a stroke mimic. Stroke mimic's an important concept because if you think about it, any drug we give, if we give it to the person who's got the disease, it might have some benefit. It also, drugs all have some harm. You're always balancing benefit and harm. The closer you are to hitting the right target, the more likely the benefit is to outweigh the harm. If TPA works, which I personally don't believe it does, I think overall, even in the right patient, it causes more harm than benefit, but we'll talk about that a little bit more later. But if it works, and according to the NINDS trial, NINDS, which is the seminal trial published in 1995, that's the one study, the only randomized control trial, which said it does work in the right patients. And you've all heard about the NINDS trial, and it said there was a 33% better if you had TPA than if you didn't. We'll talk about that in a second, but I just want to point out, what does 33% mean? You save 33 out of 100 patients? No, you actually save about 12 out of 100 patients because that 33% relative benefit. The absolute benefit was from 39% to 27%. That's a 12% benefit, and that's a relative 1/3 better. So you often hear the word 33%, and then they even extrapolate and say, well, we really think it's even better than that, but they're talking about 12%. That's the only study that showed benefit, or that claimed to show benefit, and that was 12%, okay? That's sort of the background stuff. If it's true that if you treat 100 strokes, 12 will do better, but, you know, there are some of the people who actually get harmed. About 6 out of 100 will get a bleed, and half of them will die. Even so, 12 better. If you're balancing, that looks pretty good. 12 out of 100 better, that's a good result. But what about if you treated the wrong patients? You're still going to cause bleeds, but now you're not going to get any benefit, right? So it's really important to know, are there things that look like a stroke that aren't a stroke? In the NINDS study, they had super experts, and they had very few stroke mimics that they treated. Everybody they treated really was a stroke. What about the rest of us? So how often do you see a patient looks like a stroke, it turns out it's not a stroke? Well, there was a study in 1997 or something like that by a guy named Libman, where a stroke team looked at this, and they found that 19% of the patients where they thought it was a stroke turned out not to be. These were not ordinary doctors. These were a specialized stroke team, 19%. If that's true, and in practice, 1 out of 5 patients we give it to us doesn't even have the disease, you might get rid of that 12% benefit, right? You're hurting some and not helping, right? Subsequently, other people published information where it said, well, it's not 19%. Some people said it was 15%. Some people said it was 10%. The lowest, somebody said, was 5%. This might be important if we're trying to do benefit versus harm. So I thought it was worth including this paper, 350 stroke team activations, not the ER doc, stroke team. The stroke team got there, what did they think? What percentage of them turned out to be a stroke? 69%. 31% were a mimic. And by the way, when they're talking about strokes, the 69% wasn't just strokes, it was strokes and TIAs, which is another place where you really don't want to use TPA, right? So only 2/3 turned out to be the disease. And in that 2/3, there were some, they don't tell us how many, who really shouldn't have gotten TPA. Now, I suspect that this may be more than in all the strokes you see. And I'll tell you why. It's really an important number, right? If you treat 1/3 of the patients you treat don't have the disease, we could easily overwhelm any benefit that the drug might have, even if it had benefit, which I don't think it does. Anyway, so why is it, supposing it were true that, my belief is that probably there's about 15% of things that we see that turn out not to be a stroke. And they found over 30%. How'd that happen? Could be random variation, but I think there's actually an explanation. So let's go back for a second. What percentage of the patients you see with a rule-out stroke qualify for TPA? And qualifying basically means there's a bunch of exclusions, but the most important is they're under 3 hours. And in fact, if you really want to be honest, they have to be under 2 hours, right? Because it takes an hour to get it done. 2 hours from the last time you're sure they were normal. So most of the patients we see, in the middle of the night, you can't tell when it was, right? So what percentage of strokes are candidates for TPA? What do you think? So the interesting thing is that the number is probably about 10% who are candidates, but only about 2% or less, 1 to 2% actually get the treatment. And I'll give you that information in a second, but why do people not get treated when they're a candidate? They meet the inclusion criteria, they still don't get treated. Why? Smart doctors might be one reason. ER doctors, good. What else? Because the patient is getting better, or they have a trivial deficit. That's the vast majority who don't get treated. So we only end up treating about 2%. Now, I just wanted to suggest to you that the reason that they found 30% mimics instead of 15 or so, which I think is probably closer to the true number, is because this was stroke team activation. So think about this for a second. Most of the people who don't qualify, it's because they don't meet the time limit, right? It's too long. It was the middle of the night. What percentage of mimics don't meet the time? So what are mimics? What are things that look like a stroke but turn out to be something else? When it's something else, what does it turn out to be? Seizure, postictal, hypoglycemia, it's a metabolic event, a brain tumor, which is rare, but mostly infection, metabolic event, and seizure, and migraine. What percentage of them happen in the middle of the night and don't meet the time? None. Those are the people who qualify, are the mimics. He had a seizure, they raised him into the ER, he's abnormal, and guess what? He shouldn't be getting the drug. So if you look at the group who qualify, it's not surprising that it's a much more substantial bunch of those who really don't have the disease. Because they all meet the criteria, many of them meet the criteria, as opposed to most strokes who don't. So if we were to treat people who looked like, oh, I better give them TPA, a lot of them might turn out to be a mimic. And that would be really bad because you could get the harm and none of the benefit. So if there was a small benefit, in actual real life, it might be overwhelmed by the fact that you're treating the wrong group. That's an important thing. And I thought it was interesting, this is a stroke team, they published it 30%. We just did a paper yesterday, and another one of the tapes that we did, where it's 25%. High number. It could easily overwhelm some benefit. Then the next series of articles, and I tried to include articles that are recent about stroke, and so there's 3 or 4 articles which say, you know, it performs just as well in the very old as it does in the young, or just as poorly, however you want to look at it. And I think that's true. If you actually look at outcomes in the very old, they're worse. But outcomes without TPA are also worse, so that the relative effect is about the same. Okay, so worth just mentioning that. If you're going to use it, age shouldn't be a thing. Now, the next series of articles, 8, 9, and 10, are about what's called effectiveness. There's a difference in epidemiology, the term effectiveness and efficacy. Efficacy is what happens under ideal circumstances, like the NIND trial. You got stroke experts and neuroradiologists and stroke teams and ICUs and all that stuff, versus what happens if we apply it in our practice. That's called effectiveness in real life. And there's almost nothing which we do as well outside of the attention of a trial as we do in a trial. There's almost nothing. But there's lots of reason to believe that in this case, it could be even more important of a difference, including what if we include mimics? They didn't include mimics. Including what if we miss subtle hemorrhage in the brain, which it's been shown we all miss. Neuroradiologists are pretty good at it. Everybody else, including radiologists, neurologists, and emergency physicians, miss subtle hemorrhages, miss maybe 1 out of 5. Now, just think about it. If you have a subtle hemorrhage that you don't see, just a little tiny hemorrhage, it's really not an acute ischemic stroke, it's a bleed, but it's a real little one. If you wanted to kill that patient, what would be the best way? Well, you could take a gun. That would be pretty good. But next to that, TPA would be a pretty good way to kill that patient. So one could imagine that doing it in the community, if we missed these subtle bleeds, if we missed mimics a lot of the time, that could be bad, right? There's nothing about giving the drug that's dangerous. We've all given the drug for heart disease. You can give the drug, but if you get it wrong a little bit, and one other way that's really bad, one other thing that might be bad about community use is we use it so rarely. And we're under such pressure to use it. And especially if your hospital wants to become a stroke center and you have to give TPA and we haven't given it in 9 months, then you might want to cut corners a little bit. Well, they really don't quite meet the exclusion criteria for blood pressure, but I haven't given it. I better give it. Or, well, maybe it's not really 3 hours, it's 3.5 hours, but same thing. I don't really know for sure when they were last seen normal, but let's do it. There's a lot of pressure on us to do this. I might get sued if I don't do it. So we might do it, and if you do it in the wrong person, that's really bad. It's been well shown that when there's a protocol violation, outcomes are worse. And how many people who get TPA in the community have a protocol violation? The majority. So that's a little bit scary. If we do it wrong, maybe even if there was a little benefit, it might turn out to be really bad, right? So that's part of all of this stuff. The next 3, 8 to 10, are how did we do in the United States when we've used this? Now, in the past, we've reported some of the most important effectiveness studies, which look at a whole community, how did they do it, careful follow-up. And the famous papers by Louise Katzen from Cleveland and by Bravata from Connecticut, where they looked at everybody who got it in their community, small numbers, but everybody who got it, the results were terrible. Lots of protocol violation, lots of hemorrhage, lots of death, and terrible outcomes. Now there are 3 papers here that were published in the last 2 years, year even, which are huge numbers and pretty much the same thing. No publication bias. They looked at all the patients who got it. They looked at these big data sets, and they don't have quite as much information as those 2 smaller studies, but they have some information. All 3 of them show the same thing. And by the way, the first one is 2,500 strokes who got treated. We don't know how many didn't get treated. The second one is a national database of 250,000 strokes, of whom 1% got treated. 1% of all the strokes. The third one is 100,000 strokes, 99,000, 1.2% got treated. So we're talking about very, very small numbers who got the drug. In each of those last 2, close to 10% sort of qualified, but didn't get treated. Why? Because they were getting better, or they were too mild. So the numbers are sort of consistent, very, very large numbers. What happened to these patients who did get treated? Well, these are not randomized, so there's nothing to compare it to, except you look at all the stroke scores that say, here's what we think would happen if you had this stroke ordinarily, and you compare what actually happened to these patients. Or you look at the ones who got treated versus the ones who didn't get treated, and what are the results so? Terrible. Lots more mortality, lots of bleeds, and interestingly enough, not all of these, but 2 of these papers actually looked at morbidity, which, remember, in the NINS trial, it was supposed to be, nobody claims that this saves your life. In fact, all the studies except for NINS showed increased mortality. But they said it doesn't save your life, but it does save your brain. You'll have better 90-day morbidity, less dependence. So these three studies, 2 of the 3, looked at 90-day dependence. And what did they find? First of all, they found lots more mortality, 3 times the mortality you'd expect. Not a little, a lot more mortality. And you'd think that if you killed off the really bad ones, at least the morbidity would be better. If the morbidity was a little better than expected, that still wouldn't prove that it was actually helping. It was just that you killed the sick ones. But in fact, these studies show terrible, not a little, terrible worsening of morbidity. 30% dependent versus 55% dependent. So in these studies, in the United States, huge studies, in actual practice, the outcomes were really, really bad by all measures. Again, it's not a randomized trial, so I can't say it's for sure, but the numbers look really terrible, much worse than you'd expect. There are 2 other articles that I want to mention in here. I'm going to run over by about 10 minutes because I got it 5 to 10 minutes because I started 10 minutes late and because I got to tell you this. There's some really interesting information. Last month, the Lancet published a paper called the SITSMO study, which was another effectiveness study from Europe. How many of you have heard about this? Well, they're trying hard to make us hear about it. My edition of the Lancet comes every week. It's got a white cover, and on the white cover it says in the corner, The Lancet, and then in the center it has some statement from the issue, and that's it. It's really dramatic, this white page with one statement, and it's usually about one of the articles, and in this issue, the thing on the cover was, TPA is safe and effective in stroke. That's a pretty dramatic statement. You know, you see that, it's the Lancet, pretty good, right? And it was based on this study called the SITSMO study. And I'm not going to spend a lot of time telling you about the SITSMO study, but it's an extraordinary embarrassment to medicine and to the Lancet. So what is the SITSMO study? It was an effectiveness database, registry, of people who used it in Europe. And they said, they didn't mention any of these 3 studies that I talked to you about. They didn't mention that in the United States, where it's been looked at, huge numbers of patients, the outcomes are terrible. Instead, what they said was, we looked at our people who used it and they did well. So here's what they reported. 6,000 patients, huge number, got treated, and they did well. And in fact, they said, we compared them to the results in NINS, and we did just as well, even though we weren't having experts, and a lot of these hospitals had never used it before, and the results were really good. And the way they said the results were really good was they didn't have that many hemorrhages, and they didn't have that high mortality, and the modified Rankin score at 90 days, which is the way you measure morbidity, was just as good as in NINS. That sounds pretty good. Sort of hard to reconcile with all of this. In the States, we're killing them off like crazy. They're all dependent. And in Europe, these people who had never done it before, they're getting great results. So why do I say it's a little bit of an embarrassment? So first of all, you have to ask, what did they actually do? So the first thing is, they said this is every patient who got it. All the hospitals, it was all the patients they treated. Oh, wait a second, we don't actually know if that's true. We encouraged them to tell us about all their patients. We have no idea how many patients they treated. That's sort of, okay, that's sort of interesting. Maybe there's some missing patients who didn't do so well. But what were the outcomes? The outcomes were this thing called a modified Rankin score at 3 months. How did they determine what that was? They went and examined the patient, right? No, they don't actually tell us. All they say in the methods is, we determine it by face-to-face interview or phone call with the doctor or the patient or a relative, or by lettergram. That's sort of interesting, how you evaluate neurologic function by lettergram. They don't say who lettergram, with whom, or who read the lettergram, or how they interpreted it. They just say it was by lettergram. By the way, all the data is owned by and controlled by the manufacturer of the drug. And then, so that's sort of interesting. And then they also say, who were the patients in the study? So in the NINDS study that they're comparing it to, we're comparing apples to apples, right? In the NINDS study, it was all strokes. In this study, it was mild strokes. It was only people who had an NIH score of 24 or less. That's mild or sort of moderate. In the NINDS study, all the people with the big strokes had terrible outcomes. And the people with the little strokes had good outcomes. So they're comparing the little strokes to all the bad strokes. Sort of amazing. How could you do that? We did just as well treating diabetes as the experts did. We treated the ones who had no symptoms. They treated DKA. I mean, it's astonishing that people would get away with that. It says right there, it's only the small strokes. And then the coup de resistance, the best part, is they don't mention it in the paper, but in the accompanying editorial, which says how fabulous this is and how great it is, it said one of the great strengths of this study is that they systematically excluded all protocol violations. Did you know what I just said? We're looking at how well you did it without experts in the community. We know in the community, half the time we do it wrong. We excluded those, we didn't look. We don't want to know about those. It's sort of like saying, watch the X Games on TV, see those death-defying stunts? Let's see if we can do it. Okay, we do it, and we don't count all the ones where we missed. And the ones where we were able to do it, we did just as well. You can try it at home. Let's not look at all the ones where we crashed. Sort of astonishing. I mean, to me, it's really astonishing. That the Lancet would stoop to this is, you know, it just shows what the last two articles are about here. And the last two articles, or last four, I just mentioned to you in the interest of time, I'll just get to the end. Number 12 is Stroke, a Legal Quagmire. It's by a New York academic neurologist who says, let's see what's happening in the courts. And he says, gee, it looks really bad. All these doctors are getting sued. There's all this big controversy. All the emergency medicine organizations say it's not the standard of care. Every one of the ones of the four big organizations in North America says it's not the standard of care, and doctors are getting sued about it. How could that be? Should that be how we resolve controversy? And the last one was an editorial I was asked to write, one of many I've been asked to write about this, and this one I think was from Australia, where I basically said, you know, this is really troubling. And the reason it's troubling is not because we're going to kill all these people with TPA, but because there's this big controversy. I didn't go into all the reasons why I think even the NINDS trial is wrong, and there is no advantage. And certainly in clinical practice, we're killing people, and yet this discussion is dominated by advocates, zealots, who are telling us we must get on. I left out a couple of the ER articles that are in there where they say, we're not using it enough. Why are we so stupid that we don't use this drug enough? It seems to me, and then there is legislation in the United States on a national level, on many states and many communities, which mandate use of TPA if you want to be a stroke center. The JCAH regulations, they're making all this stuff about stroke centers. So to me, what's really troubling about this is the way in which money, this is all about money, I think, and politics and legal stuff is come to dominate what should be a medical discussion. 5 years ago, none of you, very few of you were ever using this. In the next few years, unless something changes, we'll all be using it because we're being forced to. I'm sure this will be a pay-per-performance issue. You want to get paid, you got to use it. And to me, that's really bad. That's why I'm so passionate about this. I will tell you, I'll stop now, except I'll tell you one other little thing. It's a sneak preview. Don't show this to anybody, okay? We have just submitted a paper to one of the major medical journals where we finally, after 10 years, the NIH released the data, the raw data from the NINDS trial. for many years, even though it was paid for by your money, nobody could see it except for the people who were the big zealots. And they finally, under pressure and Freedom of Information Act, did release the data. And I got the data about 2 years ago, and unfortunately, I put it in a drawer, and I didn't look at it, because I thought, you know, the MINS is one study, and you know, there are some problems with it, but it's not really important. So one study came out a little better, no big deal. But I thought eventually I should look at it, because there were some things that were sort of suspicious about the data. And I can't tell you what we found yet. And I hope in a year it'll be published and I'll be able to tell you. But I can tell you that what we've submitted suggests that, in fact, I mean, it doesn't suggest it, it shows absolutely without any question that there was no difference between the TPA group and the placebo group in NINS. None, zero, except for more hemorrhage with TPA. That's all I can really tell you now. If I could show you the graphs that we created based on the raw data from 624 patients, you would be astonished. In fact, one of the things that I have been doing is showing the graphs of the 4 different treatment groups: early TPA, late TPA, early placebo, and late placebo, but not labeling them, and asking people, which group do you want to be in? And they go like, what, are you crazy? There's no difference. They're exactly the same. And in the paper, we'll see if they publish it. There's already a lot of political stuff about this. That's one of the questions we had. One of the first statements he said is, it is amazing that in the United States, doctors are being sued for not using treatment B, graph B. I think it's shameful, I think. And we'll see what happens to that publication. Hopefully, it will see the light of day soon. I'm really hopeful. But that's where we stand. So I'll stop there. Any questions, thoughts, comments, whatever.